Alright, this is going to be Chapter 9, the General and Special Senses. This is going to be Part 1. Introduction. All sensory information is picked up by sensory receptors, and these are pretty much going to be specialized cells that monitor the conditions in the outside world. Simplest receptors is going to be from the dendrites, so somal body and all the dendrites, and then this is going to be communicating with other areas. Branching tips are called free nerve endings, and the area monitored is the receptive field. All sensory information is in the form of an action potential, or the electricity that goes down a neuron and its axon. The arriving information is sensation. Conscious awareness of sensation is a perception. And this is the areas that we're talking about. These are the dendrites here. This is axonal body. And then this is sheathed or myelinated nerve endings. And then this would be the receptive field that nerve ending is actually providing sensory input for. Adaptation is a reduction in sensitivity in a presence of a continuous stimuli. So if we continuously stimulate something, what we're going to get essentially is a reduction in sensitivity. And why that occurs is because the body adapts. General senses are temperature, pain, touch, pressure, vibration, and proprioception, which is body position. Special senses are going to be smell, taste, vision, balance, and hearing. The special senses. We have pain, temperature, touch, pressure, and position, and then chemical detection. Pain. Pain receptors or nociceptors are free nerve endings, common in superficial portions of the skin and joint capsules, sensitive to extreme temperatures, mechanical damage, dissolved chemicals from dissolved chemicals of the cells. We have fast pain, which is on myelinated fibers, and they reach the CNS very, very quickly. And then we have slow pain, which occur on unmyelinated fibers, and they reach there a little slower. And then also we have something called referred pain. Mechanism is not clear, may follow the dermatomes. So as we were looking in the spinal cord chapter, and we had these dermatomes, so if we had a spinal cord sever, this whole area, that all of these sensory receptions going into the dorsal horn would actually fail. We would have paralysis on this. So what we might get is if something is in this dermatome section, given as pain, the whole area or the region may actually feel like it's having pain from that. Example of this is going to be chest pain, or referred pain into the arm or jaw. And examples of referred pain, the liver and gallbladder, and it can be up into your right shoulder, and then your heart, and this is anywhere in this area here. And some people can have atypical pain and come all the way down into this area, which would be epigastric pain or stomach pain. Stomach, appendix, and then colon pain, and then ureters. So if you actually get a kidney stone, it generally goes from your back down into your inguinal area. Temperature. Thermoreceptors are free nerve endings located in the dermis and the skeletal muscle, in the liver, and in the hypothalamus. Cold receptors are pretty much more numerous than the warm. Temperature is relayed along the same pathways that carry pain sensation. Clinical note on pain. And pain pretty much is complex, but it's also subjective, because you're going to have people that can take pain and you're going to have people that cannot. All patients should be assessed for pain, and we should do that in the form of a scale, 10 being the worst pain you ever felt in your life. What do you think this pain is? And let's say that they set a 5. Also make a mental note that you put what their 10 pain was. NSAIDs are non-steroidal anti-inflammatories, which pretty much decrease inflammation. And then we have opioids, which are narcotic based, and they pretty much work on the mu receptors. As we get to this a little later on, as the sensory input comes into the dorsal horn, the mu receptors are right here. So if you have an opiate, or like morphine, it will work on these mu receptors and decrease the amount of sensation that is occurring. The endorphins and enkephalins are your body's own naturally occurring opioids. So runners get a runner's high from endorphins. An example of this, if you've ever heard someone get a runner's high, they'll run to the point that their body releases endorphins, or they'll lift weights till their body releases endorphins. Now, these endorphins work just like our opioids, and whenever we use opioids, we're going to see that they also act just like endorphins. So whenever we give someone morphine, thank goodness, it works exactly like our own body's natural endorphins and enkephalins. 2.5, touch, pressure, and position. We have tactile receptors, baroreceptors, and proprioceptors, which tactile is going to be touch, baro is going to be to do with our blood pressure, whether we're sitting or standing, and then we have proprioceptors, which will give us our position. Tactile receptors, touch, pressure, and vibrations. Fine touch and pressure receptors provide detailed source of information about the source of stimulation, the location, size, shape, texture, and movement that's actually occurring. So you can feel if something's rough or smooth, how big this thing is, just by touching it without even visually seeing it. Crude touch and pressure receptors, poor localization and little additional information about the stimulus. Types of tactile receptors. We have free nerve endings, and they're sensitive to touch and pressure between the epidermal cells. We have hair root plexus, free nerve endings stimulated by hair displacement, kind of like a cat or a dog with its whiskers. Tactile discs, fine touch and pressure, deepest epidermal layers. And then we have tactile corpuscles, sensitive to fine touch and pressure, low frequency vibration, eyelids, lips, fingertips, nipples, external genitalia. Lamellated corpuscles, Pasolini, sensitive to deep pressure, skin, fingers, tips of breast, and external genitalia, joints, mesenteries, pancreas, urethra, urinary bladder, and Ruffini corpuscles, which are pressure distortion of the skin, and these are going to be in the deepest layers of the dermis. These are all of these free nerve endings, hair root plexus, tactile discs, deep layers, Ruffini's corpuscles, these again, dendrites in this area to provide sensation, lamellated Pacini corpuscle here, which these are dendrites, or a tactile corpuscle, and this is pretty deep. This is the epidermis and then the dermis layers here. All of these provide sensation. 2.9, baroreceptors provide information essential to the regulation of autonomic activities by monitoring changes in pressure. And what these things are going to do is the baroreceptors that work on your blood pressure are located in the orchivari aorta and your carotids. So if you stand up, you're going to require more blood pressure. Baroreceptors of the lungs provide information on lung stretching to respiratory rhythmic centers, so you won't overexpand or blow an actual lung. Baroreceptors of the digestive tract provide information on volume of segments, triggering reflex movement of the materials along the tract. They provide information and volume of fecal material in the colon and trigger defecation reflex. And then baroreceptors of the bladder provide information on the volume of urinary bladder triggering urinary reflex. Baroreceptors work off of pressure. Proprioceptors monitor position of the joints, ligaments, and tendons. Chemical detection. You have chemoreceptors respond only to water-soluble and lipid-soluble substances that are dissolved in the surrounding fluid. And you have these in the carotid bodies near the origin of the internal carotid arteries on each side of the neck. And you also have these in the aortic bodies, located between the major branches of the aortic arch. Now what these do, these chemoreceptors, is they pretty much respond to changes in pH and CO2 in the body. This would increase respiratory rates accordingly. If your pH was dropping and your CO2 was rising, a good chance you're going to hyperventilate or blow off some of that CO2 pretty well. Chemoreceptors in the carotid bodies, aortic bodies, and then in your medulla oblongata of your brainstem. All of these would monitor respirations and pH and CO2 in the body. The special senses, we have smell, taste, vision, equilibrium, and hearing in the special senses. And 3.1 is going to be the smell, the olfactory pathways. The sense of smell is olfaction. Is provided by a pair of olfactory organs. This is located in the nasal cavity, consisting of the olfactory epithelium, olfactory receptor cells, and the olfactory glands. The olfactory pathways. Olfactory bulbs where first synapsis occurs. Only type of stimuli that reaches the cerebral cortex all by itself without synapsing or moving through the thalamus. So you get a direct line to your brain on the olfactory pathways. And these are the nerve bundles here, olfactory tract, and this is going to go directly to the brain. Do not pass go, do not collect $200. This is going to be the epithelium in the nair, and this is going to be the plate of the ethmoid. And this is the bone here. Loose connective tissue and olfactory epithelium, and you don't have much tissue in between your olfactory epithelium and your actual brain in a couple of locations in your sinus cavities. So this very rapid way of getting sensory information there is why smell is one of the most prominent senses. 3.5, taste, the taste pathways. Taste receptors or gustatory receptors are distributed through the surface of the tongue. Taste receptors are special sensory structures called taste buds. They lie along epithelial projections called papillae. You have gustatory cells, slender sensory receptors, and the primary taste sensations are going to be sweet, salty, sour, and bitter. Now, these are kind of in location, sour, bitter, salty, and sweet. This is a taste bud kind of blown up here. And these are going to be our gustatory cells, and these are going to actually jack right into our nervous system or our taste sensation. The taste pathway. Taste buds are monitored by the facial, glossopharyngeal, and vagus cranial nerves. All right, and if you have any question over this, this is part one. This ends part one. Feel free to contact me. My name is Roy Smith. Phone number is 405-219-7613, or you can reach me at smithr@emsa.net. Thank you.